We go on to the next talk by Dr. Manoj Prathapan. Manoj is going to speak on understanding the angles in glaucoma. As you all know, Manoj is the professor in ophthalmology at the Amrita Institute. He did both his MBBS and MS from Amrita and then did a glaucoma fellowship from Arvind Madurai. He has presented many papers and posters in national and international journals. Over to you, Manoj, for your talk on the angles in glaucoma.
Thank you, sir. Good morning to all. At the outset, let me thank Dr. Lita for giving me this opportunity. I'll be discussing with you about understanding the angles in glaucoma. So what is the relevance or importance of this talk? Glaucoma is not one entity. You have various ways glaucomas can present, and each of these varieties of glaucomas present differently. So it's important to know the mechanism of glaucoma along with the iris configuration and knowledge of the angle. We come to the mechanism of glaucoma, and based on this we will know the disease course. Some of them are very aggressive disease like say NVG, which can cause blindness in a matter of weeks or months, whereas some of them are more quiescent, some are slowly progressive, and the treatment also differs widely. Some require cycloplegic, some require pilocarpine, some of them require just medication, some require surgery. So all depends on the mechanism. First, to the normal anatomy of the angle. Here you see a normal iris configuration. The grayish band here is the ciliary body band. Then we have the scleral spur anterior to that. Then the pigmented trabecular meshwork, the anterior non-pigmented trabecular meshwork, and the Schwalbe's line. This is a pigmented trabecular meshwork, more pigmented than the previous photograph. We can classify the disease as the angle as open or closed. I will not confuse you right now with what is occludable. So let us look what is open angles. So on slit lamp examination and straight gaze gonioscopy, if there is a normal iris configuration and a visible aqueous access to the posterior trabecular meshwork with the posterior structure visible on gonioscope being the scleral spur or ciliary body band, we can call it an open angle. So what are the types of open angle glaucoma? We have primary. When there is no obvious cause for glaucoma, we call it primary open angle glaucoma. Whereas when we have underlying disease which is causing this glaucoma, we call it secondary open angle glaucoma. So in that there are three subtypes: the pretrabecular, trabecular, and posttrabecular. The pretrabecular, like something is clogging the trabecular meshwork, pseudoexfoliation or pigmentary glaucoma, the open angle stage of neovascular glaucoma, siliconoid-induced glaucoma. Then the trabecular type like steroid-induced glaucoma or angle recession glaucoma, and the post-trabecular like raised episcleral venous pressure, carotid nerve fistula. This is an example of the pretrabecular type of glaucoma. NVG, you can see new vessels on the iris as well as in the angle. This is a normal iris configuration. We can see the scleral spur, and anterior to that the pigmented trabecular meshwork has a lot of new vessels. This is a hyperpigmented angle. You can see the trabecular meshwork is pigmented here. Some of the angles have diffuse dense pigmentation, whereas some of the angles have patchy hyperpigmentation. So whenever you see hyperpigmentation, suspect pigment dispersion, pseudoexfoliation, primary angle closure glaucoma, or stroma. This is trabecular mechanism. This is angle recession glaucoma. What you see here is the broad irregular ciliary body band seen in angle recession glaucoma post blunt force injury to the eye. This is a post trabecular mechanism. What you see here are the dilated episcleral veins and blood in Schlemm's canal. Next, much more complex issue, closed angle glaucoma. We have primary as well as secondary glaucomas. The primary glaucomas all have pupillary block as the mechanism of glaucoma. We have another thing that is plateau iris configuration, which I will be discussing in detail later in the subsequent slides. In secondary glaucomas, we have pupillary block glaucomas, the pull mechanism glaucomas, and push mechanism glaucomas. Now let us figure this out with the help of iris configuration. So what is a normal iris configuration? So you can think about a mushroom head. This kind of looks like that. You have the cornea convexity, anteriorly and a mild convexity of the iris posteriorly. Mild convexity is there for all of us because we have a relative pupillary resistance, which causes a mild pressure differential between the posterior chamber and anterior chamber, so the iris is slightly convex anteriorly. When you have an exaggeration of this, we call it pupillary block. So when there is a pupillary block or increased pupillary resistance, the iris becomes more convex. So this convexity, when it increases, it closes the angle and causing angle closure glaucoma. So this can be primary or secondary. Secondary means there is some other obvious cause leading to the pupillary block. So this is the uveitic 360-degree posterior cynic case which is causing pupillary block. You can see the iris convexity. Another pupillary block, you can see the iris convexity. Next is a steep iris configuration. This is different from the pupillary block convex iris configuration. Both of them have narrow angles. So if you do a Van Herrick's test, both will show a shallow chamber. So it's important to put the light through the center of the eye so you can get to know the contour of the iris. So steep iris looks different from convexity. Here both the central as well as the peripheral AC is shallow, whereas in pupillary block glaucomas the central AC is formed. So here you can see a post-incisional surgery with malignant acute misdirection syndrome. The peripheral AC is, or rather outside the pupillary area, the entire iridocorneal area is in contact, and there is small central slit-like AC in the pupillary region. So post atropenizing the eye, the AC will be formed. This will be the appearance on gonioscopy when you have steep iris, like a push mechanism glaucoma. You will not be able to see the angle structures, but through the pupil you will be able to see the ciliary body. Through the pupil, through the lens. Next is a tended up peripheral appearance. So the central AC is nicely formed, but the peripheral AC, there is a synovial pull mechanism causing the peripheral AC to be adhered to the peripheral angle. This is a synovial angle closure. You can see those tended up appearances. So diffuse and multiple focal passes are there. This is the case of uveitic synovial angle closure. You can also have flat iris configuration or concave iris configurations. Concave iris configurations are usually seen in pigment dispersion syndrome. So when do we call it narrow or closed? So on straight gaze gonioscopy, when you see a negative visible access to the posterior trabecular meshwork. So when you see a condition like this, the possibilities are either it is an occludable angle or a closed angle. So what to do after straight gaze gonioscopy in such a situation? Then you do a manipulation gonioscopy. So when you have a hill and you cannot see what is on the other side, you have to climb up the hill to see. So similarly, move your gonioscope in the direction of the angle which is to be examined. And then if you can see the structures, angle structures, then it is just a steep iris or a convex iris without any oppositional cynic case. So you can call it an occludable angle. Whereas if you don't see, then you have to go for an indentation gonioscopy. So indentation, if you can open up the angle, then there is no cynic case, it is just an iridotrabecular contact or a appositional angle closure. Whereas if you are not able to open up the angle, then it is a synovial angle closure. So here you can see convex iris configuration on both sides, and you will not be able to see the angle on gonioscopy. So as the indentation is given, the area where there is no cynic case, the angles will open. The iris morphology changes from convex to flat, and then angles are seen opened. Whereas here, whether there is cynic case, you will not be able to open up and see the angle. This is one of the examples. On straight gaze gonioscopy, you are not able to see the angle structures. So after giving indentation, the angle opens, and there is no peripheral anti-cynic case. Next is plateau iris configuration. Here, this is slightly underreported, underdiagnosed condition, but it's quite common. Happens due to an anteriorly inserted ciliary body. So the peripheral iris have to move over the ciliary body shape to get inserted into the angle. So you may have pupillary block as a component in these cases, and PA is usually done. And this mechanism is independent of pupillary block. So usually it is diagnosed after the laser PA, because many times we don't do indentation if you are using a single mirror gonioscope. So after laser PA, when the angles are not open, you do an indentation gonioscopy. You see that there is a double hump appearance. So let's look at it. So this is how it appears. So you cannot see the angle because of this climbing up of the peripheral iris and crowding of the angle. So as you do indentation, the mid-peripheral iris moves backwards, whereas there are two humps. One is because of the convexity of the lens, and one is because of convexity of the ciliary body. We can also call it a sine wave. Finally, let me just a slide on grading of the angle. So in grade according to Schaeffer's into 1, 2, 3, 4. 1 means it is already closed. There is 0 angle width, and it means that there is already a closure. 1 is an extremely narrow angle with 10 degrees of angle. You can see up to the Schwalbe's line or the anterior trabecular meshwork. So here the closure is eventually going to happen. 3 is a narrow angle. In narrow angles there is a 20-degree angle. The trabecular meshwork is visible. Currently there is no closure, but it can happen. There is a possibility of closure to happen. 3 and 4 are supposed to be wide open angles, and here the closure is impossible. We have an angle ranging from 25 degrees to 45 degrees, with the last structure visible being scleral spur or ciliary body band. Thank you.
Thank you, Dr. Manoj, for a very master class on gonioscopy. I think all the PGs here have a lot of questions, but there's one question which I want to ask. What would you advise the PGs to use as their first gonioscopy mirror? What should they buy?
Goldman is easy to learn because it's much more stable, but as a glaucoma consultant, we will need to progress into a 4-mirror gonioscopy because it is much quicker, it is more comfortable to the patient, and of course you have the advantage of doing a indentation gonioscopy, unless somebody is extremely a master in doing Goldman type with the indentation, but I'm much more comfortable with 4-mirror to do an indentation gonioscopy.
I have 1 or 2 questions. First question to Dr. TG. What is your indication for a UBM in these sort of situations? How often do you use it? Very quick answer.
Hello. Yeah. Honestly, I rarely use the UBM. Out of 100 up to 200 patients, I need UBM for one patient because a good gonioscopy usually gives you an idea of what is going on behind also. And with the ASOCT coming in, we don't need the UBM for what is in front of the iris. So it's when I suspect that there is an iris cyst or something sitting behind. Quite often I do the UBM to find the haptic of a lens, whether it's in the sulcus or not. That's with the ASOCT coming in, I use that for what is in front of the iris. UBM is actually a very rare situation.
Even for a Plato situation where...
How does it change my management? Plato iris configuration, I need a PI to make sure it's a Plato iris syndrome. It doesn't change my management. Other than reinventing or proving the wheel, it doesn't change my management.
You want to make a comment, Gauri?
Yeah, I agree with sir, and only thing I would add is in these secondary angle closures, you showed that malignant glaucoma. There are certain secondary angle closures where UBM is invaluable. So more than the Plato iris or other situations, this is where I would do a UBM.
Lita, in your institute, do you stop blood thinners before doing a PI? How many of you really ask for a history of blood thinners?
I don't stop thinner.
And is it really important? We do have once in a while bad hyphemas, but we get hyphemas even on patients who are not on blood thinners as well. But as a protocol or as a sort of a legal, sort of issue, do you think it's mandatory to ask for it or stop clopidogrel or aspirin before doing a PI, or you just ignore it?
I don't stop. I think if you want to stop, you need a cardiology clearance and things like that to legally stop it. And probably the risk of cardiac event is worse than the risk of hyphen.
Last few months back, my first case in 23 years, where I did a PI, and within a few minutes there was 3/4 AC hyphema. So it's very, very rare that you find it. And that patient also, you talk to them and you explain to them. They usually, I mean, it shouldn't happen to anyone, but then it is very rare, so I wouldn't stop.
Was that patient on blood thinners, ma'am?
Yes, the patient was on blood.